Hi everybody, thank you very much for coming along. I know we're getting a few people drifting in a little bit late, but we'd like to get things started. So welcome to the first day of Movember. So thought what could be a more appropriate day to have a men's health meeting. I'd like to start by acknowledging the traditional owners of the land on which we're meeting, the Whadjuk people of the Noongar Nation, and pay respect to elders past, present and future. Now, I'm just going to do a few quick housekeeping announcements. Today, unfortunately, we will be missing our last speaker of the day, Dr. Haider Bangash, who is speaking on urological cancers. He, unfortunately, is unwell, so the day will finish at about 2:15. This means that for your CPD hours, you're looking at about 4 hours for the whole day. But there is also additional reading in your workbook, and I've also emailed that out to you if you want to follow the links. So if you want to boost your CPD hours for this tail end of the year, then that's a good way of doing it. And I believe there is a way that you can use that to produce hours in, which category is it, Melinda? Not the measuring outcomes or the education, yeah. If there's anything further we can offer, I'll send that out after the event to the people who are here. Important things, toilets. If you head out to the registration desks and then just go round to the left past a pillar, you'll find there are banks of the things there. And we will have a few 5-minute breaks in between presentations as well, just for comfort breaks to head out there. If you managed to snaffle some of the parking underneath the hotel, and it was a little bit in shorter supply than I'd hoped this morning, and you've done the registering yourself using the QR code on the inside cover of the workbook. Sorry, yeah. The registration? Okay, I'll double check that. Normally it has been working to register yourself, so you can then the barriers will raise automatically as you go to leave. But you do need to park really close to the barriers. It's obviously fairly short-sighted and can't read your registration plate unless you're close up to it. But I will check out about any problems with the QR code there. Now, during the course of the day, I'll obviously catering is out there with the trade exhibitors. I'll be using a little bit of music to encourage everyone to come in. So please listen out for The Boys Are Back in Town. It's men's health. So that is all I've got to tell you for the moment, but obviously I'll be around during the day if you need any help. I'd like to now introduce to you, if you haven't already met him, Steve Cohen-Jones, who is the CEO of Glengarry Private Hospital, and also the General Manager of Ramsay Joondalup Private. Steve.
Thanks, Wendy. Is this my little clicker?
That's your clicker, yep. Use the lapel mic, or we can, sorry, that mic, or we can put a lapel mic.
Oh. We should have done a run through. I might just get you to help me with the clicker while I say a quick hello. Morning everyone, thanks so much for getting up early on a Saturday and joining us. There's been a few drop-offs, so you guys are the diligent ones, and you have my applause. How do I go forward? Which button? There's about 8 buttons on this, so it's not just that I'm a Luddite. I did want to take the opportunity just to give you a very brief update on all things Ramsay Perth Northern. It's a very exciting time for us at Ramsay Healthcare. There's an awful lot happening in the north, and it is really essential that you know about it. If you don't know Ramsay, we are actually the 12th largest employer in the country. We operate 76 hospitals around the country. We also have joint ventures throughout the world where we co-operate more than 400 hospitals. We own pharmacy, psychology clinics, allied health clinics. So we're a very large, diverse, integrated healthcare business. One of the things I think that's really important to note is that Ramsay's an Australian business. We've been going for 60 years, and our purpose is people caring for people. And it drives the way that we go about our business, the way that we care for each other internally, and the way that we care for our patients. In the north, Ramsay genuinely is your healthcare partner. So when you look at the footprint of hospitals in Perth, As you head north, you get Glengarry, where I'm the CEO. It's a beautiful little hospital. I hope you know of it. We have world-class patient satisfaction scores, staff engagement scores, and lots of beautiful services that I'll tell you more about. And then as you head north, you get to Joondalup Health Campus, which is just getting bigger and more comprehensive. And one of the things I want to take you through in the next couple of slides is just to clarify what it is at Joondalup Health Campus, how it operates, because we actually have two distinct hospitals up there which you may not be aware of. Something really important to note is if you are a GP in the Perth Northern catchment, you're in the highest growth catchment in the country. So if you're already feeling overwhelmed by the demand for your services, you can expect that to continue. So we have 37% population growth in the years ahead of us, and a lot of that population is in the 65 years and plus. So demand for health services is only heading in one direction in Perth's north. When you look at Ramsay's footprint in WA, we have a number of sites. So we have Joondalup Public Hospital, which we operate under a contract with the state. We have a very big emergency department, which caters to about 300 patients a day. Very, very comprehensive offering of services. On the same campus, we have Ramsay Joondalup Private Hospital, which is on a separate parcel of land. It's connected to the main campus, but the two operate independently. We then have Little Glengarry Hospital. We have Hollywood, which is the largest private hospital in the country with 950 beds. And then we have Adderdale Private Hospital, which is a rehab-only hospital south of the river. And I'm at pains to point this out because I think that the growth of this campus over time is just mind-blowing. What started out as Wanneroo Public Hospital over the last few decades has just grown and grown and grown, and we need to in order to meet the changing needs of the community. I have put a little green line there. I don't know if you can see it, but what I've tried to delineate is that everything left of that green line is the public campus, so it's the majority of the site. And to the right, we have a leased parcel of land that we operate as the private hospital and that we are expanding currently. In terms of what that expansion looks like, we've been undergoing redevelopment at the hospital for the last few years. Firstly, there was a $284 million upgrade of the public campus funded by the state. That's led to new clinical blocks, expansion of key services, expansion of theatre assets. And then on the private side, we're just finishing a $190 million redevelopment that's an investment by Ramsay in growing our capacity to meet the needs of your privately insured patients. It is a fact that in the last decade or so, the hospital has been at capacity for its private patient care. We need more theatres, we need more beds, we need to uplift the amenity, and that's what this redevelopment is enabling for us. So in terms of what's going to be in the private building, and we're hoping to open that around February next year, we've added 4 theatres, there's 2 day procedure rooms. We have a 30-bed day procedure unit, so it's going to be a very fast turnover, very efficient theatre complex. Above theatres, we have a 22-bed surgical ward, a 30-bed medical ward, and then there's room for additional expansion. We're also adding in a cafe into the front lobby to give our patients and visitors better amenity. We have an expansion of the hospital's kitchen underway, which means for the first time from about March next year, we'll have a dedicated private kitchen that lets us serve our patients an a la carte menu, which means great food, wide variety, at a time that suits them, which is the contemporary way that private hospitals deliver their food services, and we cannot wait to do that. The rooms are spectacular. We have a lakeside wing and an oceanside wing. The lakeside wing, self-evident that it has beautiful views over Lake Joondalup. The rooms are large, the bathrooms are large. It is a really spectacular facility. We cannot wait to welcome your patients there. We're also at the stage of wanting to create a very clear vision for the private hospital because it has felt a little bit like a small private tacked onto a very large, busy public hospital. And on the back of this expansion, we're investing in the right people, the right assets and the right services to let it flourish. So we've set ourselves the vision of offering our patients a better experience, better than they've had in the past, better than they can get elsewhere. And it's something that is a North Star for our team to continue to focus on continuous improvement. And we've built that on 4, what we call the 4 Cs. I like alliteration. It's very simple for everybody. And they are comfort, convenience, clinical excellence, and customer service. And you can see some of the key pillars there. So we're enhancing our robotic procedural capacity at the hospital by bringing in an additional Mako robot for joint replacement before Christmas. We're getting our first Da Vinci robot before Christmas, which means that we can do all the radical prostatectomies that we used to do as an open procedure, but these days, best practice is robotics. We're looking at every single element we can of the private hospital service to uplift it, and it's a very, very exciting time. So it's good for you to know about, good for your patients to know about. GP engagement is a priority for us. Wendy has done a tremendous job with Ramsay over a number of years in hosting these events, but it's not enough. So we've recently employed Christy Hass, who you get to meet today. She's here with us. She was at the front desk. She is going to be our on-the-road GP liaison, coming out to the several hundred GP practices in our catchment to engage with you, to bring surgeons in for lunch and learns, to listen to any of the feedback that you have, to act as an information conduit and to build those relationships. So we're really excited about that. Dr. Belinda Russell-Smith has been with us for a year, doing a tremendous job. Belinda represents the public campus and is a very important conduit between you and that public service. So she's the eyes and ears for the hospital, connecting to the GP community, and we really want to hear what you think. We really want to focus on continuous enhancement, and Belinda is a really critical component to giving us that connection to you guys. So we now have the three GP engagement team, including Wendy, who does a fabulous job with all of our events, and hopefully you're getting our bi-monthly GP newsletter as well, because you guys are critical. We need you to be telling your patients about our services, understanding the specialists that you can refer to, because from February we have significant capacity. We're doubling our private patient capacity on the campus. I can't forget about Glengarry, my other baby. Glengarry's been around for 50 years. It's a beautiful little community hospital. It's gone through a lot of changes, a big one of which I've put down the bottom there, where we are closing our surgical services at Glengarry from about February next year and moving them up to the new Ramsay Joondalup private hospital, which means for the near term at least, there won't be any surgery performed at Glengarry anymore. The reason is that the new theatres up at Joondalup, they're larger, they're more comprehensive, we've got state-of-the-art equipment, it's a better facility, we can offer a broader range of surgical services to patients that live in the same catchment, so it makes sense. What remains at Glengarry is a fantastic mixed medical rehab private PAL care ward, and we, adjacent to that, have a dedicated public palliative care ward through a relationship with the Joondalup campus. We fare well 3 to 4 patients a week through our palliative care service. We perform VAD procedures with our accredited VAD partners. It is a beautiful little cottage-like environment for patients to end their days, and we're very proud of that service. The Boronia surgical ward, obviously we won't need once we stop doing surgery, so we're going to convert that to an enhanced rehabilitation ward. We offer a fantastic rehab service at Glengarry. We're then converting our ex-maternity ward into a transitional care ward for these long-stay patients that you might hear about. They're taking up private hospital and public hospital beds, and they block beds from being used for more acute needs. So we're going to have a dedicated transitionary care ward at Glengarry. We also have recently opened the Waratah Infusion Suite, so you'll find some information on your table. I'm very excited about this service. Chemotherapy is the highest growth demand specialty in the Perth North, alongside endoscopy. We have a partnership with WA Medical Oncology led by Andrew Dean, who is a force in this space. He has world-leading pancreatic cancer outcomes, just as one example. So we have 5 oncologists and we have 1 on site every day, and we have a rapid referral service with their contact details in here. So if you identify a patient that you want to get a consult same day or next day, we can facilitate that for you at Glengarry. It is a beautiful little department. I can't remember if yes, there we go. These are our oncologist friends, and these are just some sell points about the unit, but it is a beautiful little unit. We will also be doing non-chemotherapy infusions for a whole range of other needs as well. So if you've got patients newly diagnosed, you need an oncologist with quick availability, please do think of us. It's a beautiful service. Just as I finish up, I will say that to formally launch the newly expanded Ramsay Joondalup Hospital, we'll be activating a very large community advertising campaign before we open. So from about January onwards for 12 months, we will have billboards, we'll have train station billboards, we'll have radio advertising. We really want the community to know now you can get care close to home. You don't have to endure the impertinence and the traffic of travelling to the city centre to get the care that you need. You can get it close to home. Convenience is one of the #1 drivers for patients in selecting their healthcare provider, specialist and location. So please do think of us. Have a great day, and I hope you learn a lot. Thank you.
As you gathered, my name's Dr. Belinda Russell-Smith, for those of you who haven't met me before, and as Steve mentioned, I'm the Hospital Liaison GP, so I still do clinical work 3 or 4 days a week, so still got feet on the ground, but the other days I work along with this fantastic team to try to bridge that gap between us as GPs and what's happening at the hospital. Really looking forward to today. Lovely to see a lot of you coming for the 3rd Saturday event this year, having been at the women's one and the paediatric one, and now to complete the demographic, the men's event today. Just a quick extra little bit of housekeeping. You'll see on your tables there's a QR code to a GP survey. It's the first day of launching that today. We're really genuinely keen to see if you would help us by completing that today. There's a lot of things addressed in there that we've been trying to work on, so trying to keep that in mind and looking at how you would reflect on how things have been in the last few months would be fantastic. There's a strong incentive there. There's a $1,500 voucher for Crown to be won and 2 $500 dinner vouchers as well. Just make sure if you'd like to enter that, there's a link at the very end of the survey that you have to go into to put your details. That way we've kept the rest of the survey confidential. It's a little bit easy to miss that link, so just make sure you do that so you've got a chance to win that draw. So to get underway, I'd like to welcome Dr. Daniel Cheng, who's kindly going to talk to us about bowel cancer today. If your practices are anything like mine, it's certainly an area where there's a widening demographic, very interested, curious, perhaps a little bit anxious with a lot of the social media information out there at the moment around bowel cancer. And it'd be great to hear Daniel's perspective on how that's fitting in with evidence-based practice. Thank you.
Hello, good morning, everyone. Thank you, Wendy, for the kind introduction. My name is Daniel. I'm one of the gastroenterology doctors who is currently working in too many hospitals, unfortunately. I'm predominantly in Sir Charles Gardner and Osborne Park Hospital, but I also have a private practice in Hollywood Private Hospital, and over the past year has quietly snuck into Joondalup Health Campus as well. And just to a bit of like a preview for all you GPs working up on the Northern Corridor, there's exciting things happening with Joondalup and gastroenterology, not just endoscopy, and it's coming very, very soon, and I'm very excited to be updating you, and we've been talking to Belinda and Joondalup Public Joondalup Public Health Campus as well, with regards to really beefing up the gastroenterology service. So just to start off, I've got no disclosures preparing this talk. And we'll go through the agenda today. I've made the slides available for everyone as well, so if you just feel free to just listen, not take too many notes if you don't want to or need to. So we're going to be talking about bowel cancer incidence, and are we winning that war? And the short answer is potentially. And we then move on to the topic that we're all concerned about, which is early onset bowel cancer, the rising tide, risk factors and genetics, symptoms, and to focus on the young population as well, and talk a little bit about chemo prevention and lifestyle intervention, and finally, a little bit about updates about, especially about the National Bowel Cancer Screening Program. So if we look at colorectal incidence, it is the 3rd most common cancer worldwide, but in Australia, it is the 4th most common cancer now, where formerly is actually one of the most commonly diagnosed cancer all the way back in the year 2000. Now, can anyone tell me what the top cancer is? You win a free colonoscopy. Anyone? Exactly. Another mental health issue. So prostate is number one, followed by breast cancer, and then melanoma next, and lung cancer. And interestingly, there's data in the Australian Institute for Health and Welfare that actually lung cancer now has overtaken bowel cancer to be number 4 now. So colon cancer continues to drop. So if you look at the trend, we kind of peaked at about 2007, where we hit about 15,000 diagnoses of bowel cancers yearly, and it's really plateaued throughout the years, obviously apart from COVID in 2020 where it plummeted. And if you look at age standardized rates, the incidence has actually been very, very gradually declining over the years. And I've highlighted 2006 as a pivotal year for bowel cancer, which I will talk more about later. So incidence of colon cancer has dropped from 13% to 9%. And it's really reflecting the stability of the incidence of bowel cancer in our population as population grow, because the number of diagnoses of bowel cancer has stayed quite constant. It's the overall cancer combined cases that has been very gradually increasing over time as well. So looking at the statistics, it certainly seems like we are winning the war against bowel cancer. Now, why the improvement? So remember 2006. That was when FOBT was introduced as a screening program and as one of the additional pathways into getting a screening colonoscopy on top of family history in asymptomatic patients. Now, that is obviously one of the very important point where detection of polyps and adenomas has help reduce the incidence of bowel cancer and detection of more cancers. That's why you see that little spike and increasing in detection as well. But also very importantly, high quality colonoscopy and the number of colonoscopy that has performed has also increased over time as well. Now, when I say high quality colonoscopy, I still work with gastroenterologists who used to do fiber optic colonoscopies where literally they are looking through a scope and looking at the bowels and going up close to the anal canal, unfortunately, sometime when the bowel is looping. To now the more modern scopes now have AI polyp detection technology, where we are basically almost like scope monkeys, and it's detecting polyps for us without us actually needing to recognize polyps. So that technology is here now today in use in endoscopy suites. So looking at this picture, can anyone see in this photo where the polyp is? Yeah, so it's right there, isn't it? It's very subtle. Now, these are sessile serrated lesions. You see, obviously, in our reports, we put that in. And the second polyp, it may seem that it's actually right there, but in reality, that's the size of the polyp right there as well. I really want to highlight the improvement of our colonoscopes. And there is a study which shows that with the advent of colonoscopy, we have reduced the number of left-sided colonoscopy initially, but we were missing these polyps, we were missing these polyps who were more predominantly in the right side of the colon, very, very subtle. And the point I was trying to make here is that, so imagine the lining of the bowel coated with mucus and bowel and poo. It makes our life a lot harder. So what I wanted to say is that high quality colonoscopy does involve a lot of preparation from the patients, but also from GPs as well. So information for us to decide when you send the referral to us where patients are high risk, having high risk for potentially poor bowel prep, things like constipation obviously would be number one, but also if they're on things like Ozempic and Mounjaro, which obviously slows down gut transit, does increase their risk for poor bowel preparation, which hinders our ability to detect very, very subtle polyps like that. So, and also Australia is really world leading in terms of quality standards, and we have a GISA re-accreditation program which mandates us to recertify as endoscopies, when I say endoscopies and log colonoscopy cases. That's because we know that there is a threshold target of a 25% adenoma detection rate of which if you drop below that standard, each 1% drop corresponds to a 1.5 to 2% increase in missed significant lesions and increased risk for bowel cancer as well. So we have, these are the two main targets with adenoma detection, but sessile-serrated lesions as well at 4%. The good news is that the vast majority of, the vast majority of endoscopies are well above this category of 25%. The mean is about 44%, and also the mean for sessile-serrated lesions is around 12%, and a lot of us are actually well above that as well. For example, I tell my patients, based on my own statistics, if you're age above 50, my significant detection, so not hyperplastic polyps are benign and not for surveillance after. So for significant polyps, it's about 65% for all comers. So that's how commonly we find significant adenomas or sessile-serrated lesions. And it's important to note in the context of men's health as well, that adenoma detection is higher compared to female as well. So if you split the adenoma rates out, it will be about 30% for males and 20% for females as a minimum standard. So let's focus on differences between male and female. So there is a higher incidence of colorectal cancer, 1 in 19 for males and 1 in 23 for females by age 35. And why is the difference? I think the two modalities we have in terms of the best way to capture and diagnose bowel cancer is FOBT, but also actually then going on to do the colonoscopy. And if you can look at the chart, you can see that there's definitely a much higher uptake of females in actually doing the FOBT compared to males. And this is a Australian Atlas for Healthcare variation. It's really looking at over-servicing for colonoscopies. But what you can also glean from that is that the differences between the amount of colonoscopies that are performed between sexes, there's definitely a much higher uptake of females getting colonoscopy for whatever condition versus males as well, highlighting the fact that the participation of our male patients are much lower compared to females. Now, switching tack now to talking about colorectal cancer in the young. Now, there's an alarming global rise in colorectal cancer incidence in the young, especially in the Western world. And if you look, I'm sorry if it's not quite clear, but if you look at this column, these are age of diagnosis 50 to 75 years. There's a general trend, in particular in Australia and New Zealand, towards a reduction. But if you look at this one, which is 25 to 49 years old, there is a general trend and statistically significant increase, especially in New Zealand and Australia, for an increased rate of bowel cancer. It's now the most common cancer in Australian young men, and interestingly, it's much more common in females and males in this population. So between the year 2000 to 2024, there's been a 2 to 3-fold increase in diagnosis of bowel cancers in patients aged below 50. In fact, the modeling tells us that there is a 3 times risk of Australians born in the year 1990s and beyond developing early bowel cancer versus those born in 1950. So, what's causing the rise? I think it's the food, and I'll be focusing on that quite a lot today. So I am very interested in more lifestyle prevention as a valid and important intervention. So my talk will be focused on all of that. Now, to be honest, as a gastroenterologist, you would think that I would know a lot about diet and the issues with a bad diet, but the reality is all of us been through med school, and the focus is really not on what we put in our mouth. And the research about microbiome and the links between dietary intake and worse outcomes in not just obviously gastrointestinal issues, but in cardiovascular, in even mental health setting is increasing as the data from microbiome has progressed. So we talk about progressively from the unprocessed, minimally processed foods to the ultra-processed food, which is what we call the Nova 4 foods. And there's obviously logically increasing levels of processing and also increasing risk as we go from left to right. So what are the effects of ultra-processed foods? Now, what we think is happening is the issue is that there is lack of dietary fibers and hence reduction in short-chain fatty acids. And what happens with that is that there is a reduction in your microbiome diversity and increase in pro-inflammatory microbiome bacteria. And that in turn causes pro-inflammatory cytokines, erodes the mucus barrier in the colon, and increase what we call a leaky gut. And that's the constant inflammation within the gut is what we think is causing not just irritable bowel syndrome, diarrhea predominant irritable bowel syndrome, but also leading to increased inflammatory bowel diseases as we know as well as bowel cancer. So ultra-processed foods. What is the data? So and this is what I love about preparing talks as well. So I know through my research and reading through this and preparing the talk, I found that there is data, especially for men, they have a 29% increase in developing colorectal cancer, which is a statistically significant finding comparing the highest fifth to lower fifth, but no association in women. It's really interesting, and this is borne out in a second study as well. So the question is it related to genetics? Is it related to the different forms of obesity where men have more central obesity? Is it related to hormones? Or is it related to dark chocolate, which is what females have more? I honestly have no clue about that, but actually the interesting thing are some choices of even the ultra-processed foods, and potentially, I mean, while that might be a joke, it may be true that the types of ultra-processed foods that are selected between females and males makes a difference. So they are quote-unquote safer ultra-processed foods. So sedentary lifestyle. Now, we all know about the original Framingham study that was performed in the US looking at inactivity. It does, again, increases bowel cancer risk in men. This is just talking about inactivity in that study, but not statistically significant in women. Now, I want to highlight the studies. Obviously, these are quite old studies as well, US population-based health studies. The data that I presented earlier was by a US prospective study of healthcare professionals, but also nurses. So the patient population there is quite balanced. But the Framingham study is obviously a little bit more skewed towards more male predominant type patients as well. And what we find is that conversely, physical activity seems to have an incremental benefit for all comers. Now, how much benefit and how much do we need to do? Now, there's a cohort study of about 230,000 patients, and this is based on the original diet cohort study. So the healthcare professionals and nurse cohort in the US. And what they found, basically in a nutshell, is that consistency and moderately vigorous exercise is key. So either 5 hours of walking weekly, 2 hours of running weekly, and if you are at the more consistent third tertile of patients, that confers the benefits of exercise in reduction of bowel cancer. What is interesting is that as the dose increases, so if you're exercising more METs up to 45 to 50 METs, that does not give you a benefit. And being a runner myself, there is actually a concerning regression, so an increased risk of potentially advanced polyps and bowel cancer in runners as well. And that's a whole topic for another study, but the summary of that is that your runners' patients come to you with runner's diarrhea, and the whole idea of that is that it is because of relative ischemia and to the gut. And what happens in that case is that this constant ischemia, reflow, perfusion reduction causes colon inflammation, causes constant cell turnover, increased risk for cancer. That's the hypothesis at the moment. Moving on. So obesity and metabolic syndrome. Now, notice that I started off with diet and exercise, because I think the obesity and metabolic story obviously is linked to the original two risk factors, which is diet and exercise. But we do know that obesity and metabolic syndrome does increase your risk for bowel cancer as well. For every 5 kilogram per meter square increase in BMI, there is an 18% increased risk for colorectal cancer in men, and obviously that is much higher for women as well. And central adiposity, as I mentioned before, is a stronger predictor than BMI. And smoking, no surprises there. Meta-analysis of 106 studies showed a poor relative risk of 1.18, and there's a dependent relationship with increased pack year history if you are a long-time smoker. And alcohol, sorry to report this, guys, but alcohol, anyone know what is one standard drink in terms of grams? 10. So 10 grams per day is roughly 10 grams a day, 1 unit. So basically what constitutes a light drinker is 1 standard drink to moderate drinker, which is about 2 to 3, and then heavy drink is 4 to 5 standard drinks a day. And there's a dose-dependent increase in risk for bowel cancer with increasing numbers of amount of alcohol intake as well. So let's pivot over to genetics and bowel cancer. Now, the first thing to know is that 70% of initial diagnosis of bowel cancer, they do not have any family history. And hereditary conditions, it only accounts for 5 to 10% of total bowel cancer. The rest is family history of bowel cancer without any obvious genetic causes. And we know the usual ones is HMPCC, which is autosomal dominant, FAP, which is autosomal dominant, and MUTYH associated polyposis, which is the recessive gene. But there is this condition, and that's that polyp that we have called the sessile-serrated polyposis syndrome. Now, the genetic link, there is an obvious genetic link because it does run in the family, but actually identifying a particular gene defect has not been successful so far. So we think there is a polygenic cause to this, and given the number of family sort of cohorts in these cohort studies, it seems like there is definitely a very high risk. If one patient, one family member, first degree has sessile-serrated polyposis, there is a very high chance that the first degree relatives has sessile-serrated polyposis as well. So I think this is important to note as well, which we will talk more about further on in our talk. So symptoms. Now I highlighted Never Too Young, which is a health initiative by the Bowel Cancer Australia, which is a non-for-profit organization. Now, obviously for our young patients, they typically do not have any other general risk factors like obesity, well, generally speaking, and also metabolic syndrome. They are the lowest amount of smoking, and also there's also increasing trends in data to show that they are drinking less and less now compared to millennials, compared to baby boomers. And what defense do these people have then, these young people? It's symptoms. So a US NIH study of 5,000 patients diagnosed with early bowel cancer, and you stratify them, they stratify the symptoms, and the top 4 symptoms that they had, and the top 2 were abdominal pain and rectal bleeding at 54% and 31%, followed by diarrhea and iron deficiency anemia. And what this chart shows is the lag time between onset of symptoms and time of diagnosis, which that's the median time to diagnosis. So what happens is, what this illustrates is that obviously the more signs and symptoms you have, the earlier referrals get made for a colonoscopy. But in patients who have only one symptom, there is often a delay especially for abdominal pain, there's almost a 1-year delay in terms of symptoms onset and diagnosis of bowel cancer. Now, obviously, we can't send every single abdominal pain to get a colonoscopy. I think that's, so obviously the current recommended, the current CRS pathway, which I'm familiar with, says up to 6 weeks. But generally, I think it's a good guide is that, I think for me in particular, once patients come back for a second consult after simple interventions and advice and having persistent abdominal pain, I think it warrants me not access colonoscopy, but just a phone call and a referral to gastroenterologist for consideration of colonoscopy. Because, yes. Oh, it is. It is straight on. Yeah. Can you hear me when I look this way? Yeah. All right. Yeah. So I think obviously for us it's a no-brainer for PR bleeding, for iron deficient anemia, diarrhea that goes on for more than 6 to 8 weeks. We start thinking, what's going on? But abdominal pain is a tough one, isn't it? Because there's so much abdominal pain which are non-specific in nature, which is a very, and for me as well as a gastroenterologist sitting across someone who's just got non-specific abdominal pain, suggesting a colonoscopy sometimes can be quite tough, and having that discussion as well. So the role of GPs and bowel cancer prevention. Now, you have a huge audience and you're the front line. 86% of Australians see a GP every year, and this is based on actually the College of General Physicians, General Practitioners data. And a small survey shows that 56% of patients say they would act. Whether they actually do it is a different thing, but at least up here, they would act on advice from a GP in relation to lifestyle changes. So doc, what's the bang for your buck thing I can do? So obviously not ignoring symptoms and making sure we safety net these patients, especially the young patients with abdominal pain. And the focused screening questions are important in terms of making sure they do the FOBT once they qualify, and also performing undergoing colonoscopy. Now, family history is obviously important, but also taking a focused history on polyps in the past as well. Most patients would know if they have family members with multiple polyps. That should pique your interest, and it doesn't necessarily mean that you have to take a full full history. But I think if the patient starts mentioning sessile-serrated polyposis or lots and lots of polyps, I think that would warrant me to refer the patients on for consideration for colonoscopy as well. Now, to something that I'm quite passionate about, lifestyle advice. Now, I think the general rule of thumb that I live by is that, and because obviously when I see my patients, and I try to talk to my patients as much as I can about diet, apart from just fobbing them off to a dietitian, is to say that anything with a label, that's a problem. And the key thing is to focus on fresh whole foods and avoid anything with a label. And 2 hours of moderately intense exercise a week. Now, I think what I am very passionate about in terms of talking to my patients is emphasizing that actually that is part of your treatment, not the antihypertensives. Well, obviously those are part of your treatment as well. But antihypertensive, your diabetes medications, those form one part, but your lifestyle is equivalent to reduction in cancer risk. For me, that is a no-brainer for me, but it's hard, isn't it? Our patients come to us wanting a quick fix. They want, doc, can you fix my obesity? Can you fix my appetite? Can you fix this with a tablet? That's the expectation we have as well. But the reality is, I guess, life is not that simple. And the reality is that I think with these two simple advice, if they adhere to it, metabolic syndrome will improve, obesity will improve as well. And with the adoption of a healthy lifestyle, generally these patients would then, if they're smokers, if they drink too much, would be reducing those vices, quote unquote, as well. So moving on to aspirin. So what can we do? So after saying about that, is aspirin, should we sprinkle in our water supply? Now, I've got a senior gastroenterologist previously when I was in Brisbane tell me, look, if you sprinkle Benefiber in my water system, half of the gastroenterologists will be out of a job, honestly. Yeah, no more FOBTs, minimal PR bleeding, and you get the real PR bleedings, those that are actually not from hemorrhoids. But if you, a lot of our data from aspirin, again, this data is very focused on cardiovascular and extrapolation of the data, number one. And number two, again, in terms of these trials, there is also a propensity to have more male-predominant population. So you have to be careful when you interpret the data as well. And what the data basically shows is that 2.5 years of low-dose aspirin has a small reduction in number and mortality of colorectal cancer after 10 years. And this is more pronounced in proximal cancers. And we think whether that is due to the attenuation of progression of cell-saturated lesions. And basically, the current recommendation is to commence it between age 50 to 70, and the dose is between 100 and 300 milligrams a day. Now, one would wonder if the benefits you get from these patients are because these patients obviously had their metabolic conditions addressed as well, because once they are in a trial, they are obviously being targeted for their cardiovascular risk, and with advice, with treatment, medical treatment, that naturally reduces their risk for bowel cancer because they're adhering to lifestyle modification as well. We don't know. But what we do know is that the average risk patient, that's the issue, isn't it? The vast majority of our patients, once they have metabolic syndrome, they start aspirin anyway, more for their heart, with an incidental benefit for their bowels when they start on aspirin. Is whether we recommend for average risk patients without cardiovascular risk. That's the issue that we have right now. Now, the current Cancer Council Australia and NHMRC guidelines is the ball's in your court, GPs. You discuss it with the patients. But I think from our perspective, I think that those with polyposis syndrome, 100% yes. Those with high risk of familial bowel cancer without genetics, yes. But average risk patients, I think we need more data on that. So when we talk about risk, now, what is average risk? So the average risk before age 50 is about 6 in 1,000, so 0.6%. Age 50 to 75, 2.6%. And age 75 and over, 4.5%. So that's average risk. And the current, the key change in terms of the Cancer Council Australia guidelines for FOBT, as we all know, is that we've reduced the age from 50 to 45 where we start. But also there's a practice point in people aged 40 to 45, 4 years, who are asymptomatic, requesting screening, that GPs should support that and after discussion, and also to offer FOB for age 40 to 44, which unfortunately I fall in that camp now, so I need to see one of you guys shortly. Now, assessing family history risk and surveillance modality. I summarized this quite quickly. So category 1, average to less than twice average risk, so anywhere between 0.6% and less than 2%, is when you have one first-degree relative age 60 or older. So the recommendation is either 2 yearly FOBT or 10 yearly colonoscopies. Category 2, where your risk is 2 to 4 times average risk, it's when you have one first-degree relative less than 60, one first-degree or one or more second-degree relative at any age, or 2 first-degree at any age, is 5 yearly colonoscopy, 10 years before the age of first diagnosis. So the age of diagnosis of the index case is important to note as well. And finally, the category 3, where your risk is 4 to 20 times average risk, where 2 first-degree relatives, one second degree, which is at least age less than 50, 2 first-degree, 2 second-degree any age, or 3 or more first-degree any age. These patients, I would be referring to genetic counseling regardless, based on their history. And also these patients get yearly to second yearly colonoscopy surveillance. So in summary, colon cancer does affect men more than women. And there appears to be a gap in men utilizing the best screening and detection tools that we have, which is FOBT as well as colonoscopy. And that's where GPs come in play in encouraging men to engage more with modalities that help reduce the risk, increase detection of bowel cancer and polyps. And some risk factors based on population health studies does appear to affect men more than women. And there are simple lifestyle modifications that give bang for your buck benefits, including reduction in ultra-processed foods and increasing whole foods, avoiding foods with label, and exercising moderately rigorously 2 hours a week. Thank you. Oh, yeah, sorry. Yes, any questions? Yes.
We'll just bring you the microphone.
Thank you. That was very interesting. I'm a nurse practitioner in primary care. And yes, and I deal with a lot of men, homeless men, and those in the city that transgender, quite a wide cohort. But what my concerns are is the delay in the public system. If we've referred people we flagged with rectal bleeding and it's been rejected, or there's a really long wait for gastro uptake of colonoscopies. Have you got any recommendations for this?
Look, I think where patient advocacy, I think that's the most important thing. The reality is that the public system is, I work both in the public system and private system, and I do have a vested interest in trying to solve that problem, in particular looking at the northern corridor, looking up in the Joondalup. But I think my advice to nurse practitioners and GPs is that if you have a delay in patients, unfortunately, we treat a number. Our wait list is, so huge that we just have to prioritize based on who's been waiting the longest. But when you pick up the phone and call one of us and say, look, I'm really worried about this patient, we will respond. We will make sure that the patient gets prioritized. But obviously, number one is information. The more information you give us, the more we can go, yep, that is very urgent, slot the patient is. I can tell you that if you write, if for me, when I'm triaging, if you write PR bleeding plus, weight loss, I'm circling that urgent Cat 1 and I'm handing it over to my booking staff. That's what I do. So more information, patient advocacy, calling us up, and we will respond. And it's in a way beating the queue. But if you are that worried, you have to ring us.
Sorry, just on the lifestyle advice, what is your opinion about the growing number, I guess, of plant based foods that are meat substitutes, that are cheese substitutes, that are, the supermarket aisle that's got all the, because I read the ingredients and I'm very put off by that and certainly recommending my patients not to go there. But is that all part of the processed foods? Yeah,
yes, I think the thing about what ultra-processed foods is that it's the health is, for me personally, a myth. I think the reality is additives and preservatives are our enemy, and we know that from our inflammatory bowel disease cohort. We know that emulsifiers and food additives has a strong association based on population health. For example, westernization of diet in Asia, where I'm from, Malaysia. There's no such thing as Crohn's disease or ulcerative colitis, but when we westernize, our incidence has gone up as well, and it's really due to food additives. So I think ultimately the simplest way to advise our patients is that try avoiding anything, you can't avoid it, but try avoiding anything that lists more than salt, product, and or flour, and certain salt sugars. The reality is that once they start having some flavorings and artificial products, that's where the issue comes, basically. And a lot of these health foods, quote, unquote, will have that. Yes? Yes, let me turn back to that.
Second last slide, I don't know whether I missed that one, the category 3.
Yes.
What's the age of the onset of the colonoscopy? Because you mentioned at a yearly basis, but you're starting from 35 years, 30 years, when it's very high risk.
Look, it depends on, so it depends on the type of, generally these patients are patients who have a genetic component. So genetic components are very different. So generally for FAP, for example, we will start from age 20. I need to get back to you on, it's 35 generally for all the other cancers. If they have family history, but no genetics, it's 35. But generally, the general rule we follow is 5 years before the index case. So if someone has a family member who had bowel cancer at 32, we start 5 years before, or at 20.
Maybe just one final question.
Are you optimistic that the incidence of bowel cancer will reduce as GLP-1s become more prevalent?
As
GLP, yeah,
GLP-1.
Wegovy and Mounjaro, people are just eating less. That includes ultra-processed foods and so.
Look, I think it will. I think the interesting thing is it might bear out that with reduction in metabolic and metabolic risk factors and obesity, it will reduce as well. But for me, based on the data that is coming through with GLP-1, the metabolic improvements are amazing. The weight loss is, really good as well. But I guess the issue that it's not addressing is what we are eating. And I think there's more and more data on what we are eating is the one that is increasing our risk for bowel cancer. So I think that my answer would be it remains to be seen. Because given the rise of young patients with bowel cancer, and generally are not as obese as the older population, I think my conclusion from that is really diet and lack of exercise. But it's a wait and see.
Thank you
Yep.
so much. All right. Thank you, Daniel. That's fantastic. And thank you as well for all that you do for our public patients in the north. I know my CRS referred patients have certainly appreciated being able to come to Joondalup with your support. So thank you. So next we welcome Dr. Jay Nadalwala, obviously well known to most of you having been up at Joondalup for a long time. He's going to address male infertility. Obviously, most of us will find that it's our female patients who make that first presentation with fertility concerns, but as Jay will attest, often there is much more to the story. So thank you, Jay.
Just jumping in with a quick word prior to Jay. Thank you for pointing out to me that there has been a problem with the car parking QR code. It seems they've slyly switched QR codes on us. So if you are having an issue with that, there'll be one of these on the registration desk out the front and also around by the coffee station. Thank you. And apologies to Jay. Please carry on.
Don't know me, but it's wonderful to see all of you turn up on a Saturday. Thank you very much. I work at Joondalup and I've been there for 30 years, coming up March next year. We started the fertility unit there in 2002, so we'll be going 23 years. It's a fantastic unit. I'm very proud of what we've got. It's one of only 2 units that has a lot of research behind it. We have PhD students, we've got master students going through, we publish all the time. So there aren't many units that do that, but this is what we do. And we're not in the middle of town, we are where we are in a very exciting growing corridor. Now, having said that, I didn't want to make although this is a didactic lecture, I've given you notes through all of this. So what I might do is just go through some of the highlights and talk about interesting points. I'm sure you've seen this lots of times, but sources of infertility, we normally say about 40% in the females, 40% in the males, and 20% for both are unknown. But in fact, as time has gone on, a lot of this unexplained infertility is actually with the men. So I think about 55% of the causes of subfertility that we see for those patients sitting in front of me is actually a male factor. It's becoming more and more prevalent. Overall, if we think about what's going on, you've got to realize that girls are XX, boys are XY, and it's the Y chromosome that comes through completely from the father to the son. And what happens over time, through generations, bits of DNA always get knocked off. And what's happened over the last millennia, we've been losing bits of DNA. In fact, the reason why we have a Y chromosome and not a X-shaped chromosome is because over millennia, we've lost bits of chromosomes, and that's why it's ended up with a Y. And we continue through generations to lose genes. So this is not just what we eat and what we do. This is a long-term issue, and it's a short-term issue, okay? Today, I can't do much or talk to you about the long-term issue of male subfertility, but we can talk about what happens on a day-to-day basis. If we just talk about the hypothalamic pituitary axis, I'm sure you all understand this, but the pituitary is very, very important. The two main hormones we're interested in is FSH and LH. They go to the testes. FSH acts on the Sertoli cells in conjunction with stem cells produce sperm. But that can only happen if we've got a very, very high intratesticular level of testosterone. So in fact, the testosterone level in the testes is about 20 times higher than circulating testosterone. And you need that to go across the tight junctions, which I'll show you in a minute, for you to get proper sperm formation. These act back towards the higher centers, which then goes to the testes, and then you have inhibin and other controlling things where things work. And I'll show you why this is important in a little while. So that's the endocrine function. Testosterone is about 2% free in the circulation. 98% is bound to bound sex hormone, particularly in the SHBG. When you look at, one of the tests that when you look at the SHBG in men and women, particularly when you look at women, SHBG will be reflected in terms if they're on the pill or not. So if they're on the pill, there's high estrogen, SHBG actually goes down. So testosterone raises SHBG, estrogen lowers SHBG. So you might find, as an aside, if you're looking at PCOS women, you'll see the SHBG is a little bit higher than people who don't have PCOS. So it's very important. Oops, how do I go back? Okay. There are other things, estrogen, thyroid, decrease SHBG, and androgen growth hormone, obesity, decrease free T3 as well. The exocrine function of the testes is sperm. So when you look at this, the testicle is like an orange. There's lots of segments. Every segment have thousands upon thousands of tubules. Each of these tubules have these cells that I'm talking about. So this is, whoops, sorry, I go back. So this is a standard cross-section of one of those tubules. You'll see here on the outside, these are the theca cells, which responds to LH that make testosterone, which goes into the tubule. In here, you've got Sertoli cells and stem cells that produce sperm. And sperm are made, and they go into the tubule lumen here, which then passes up. Okay? So here it is again. You've got the Leydig cells on the outside that produce testosterone. You've got inside the tubule, you've got Sertoli and stem cells. Okay? So here's the Sertoli cells, and here are the stem cells. And together, in conjunction with testosterone, they make sperm, which are, once they mature up, they then get released in the lumen, and then they carry on through. We'll talk about the process of sperm being made and transportation in a while. It takes, so once the sperm is released in the lumen itself, it takes about 75 to 80 days for that sperm to be ready to be ejaculated. So if a sperm is made in a testicle today, it's ready for ejaculation 75 to 80 days later. And in that 75 to 80 days, lots of things can happen to that sperm, which we'll talk about in a while. When you see someone, or when you see a couple that presents with subfertility, men being men, we always think it's the girl's fault. It isn't. You've got to get both of them in. You've got to try and encourage the men to come in, because the subfertility in the men is actually much more common than we think it is. You need to see what they look like. Do they have a beard? Do they look well androgenized? Ask them if they get a morning erection. Ask all of those things, because if they don't, and they don't wake up with erection, all of those things, they may not have enough testosterone. On the other hand, we have a situation at the moment where a lot of the men will go to their GP and say, I don't feel well, I don't feel strong enough, I don't feel like I'm a man, all sorts of stuff. And the amount of use of excessive testosterone out there is quite alarming. I'll come back to that as well. But you ask them about the sexual history, timing of frequency, lubricants, medical surgical history, coital frequency is quite important. It's funny because a large number of trials have shown over time, we live in such a sexualized world where people are looking at pornography and you'll think people are having sex all the time. They're not. Coital frequency is probably lower now than it has been for decades. So although we live in this funny world, they're not having sex as often as they should. Because for a woman to get pregnant, you need a constant supply of sperm at the end of the tube when the egg is released to be fertilized. But we are finding more and more and more over the decades that less and less coital frequency is giving less and less exposure to those eggs, and therefore fertility rates are much lower, and a number of people who are using fertility services rising. So, as I say, have a look at the men if you can, see if they're looking properly androgenized. If they say that I'm finding it difficult to have ejaculation, I'm not pregnant, if there's anything odd, you may look at the testes if you want to, but if you don't, leave it to us, send it to us, we'll do it, that's okay. You can examine the epididymis, you can feel for the vas, you can feel for a varicocele. Why is this important? Amongst Caucasian populations, cystic fibrosis incidence is 1 in 24, 1 in 25. And even if you're a carrier, some of those carriers may have vas problems. And if they've got a vas problem, they'll have oligospermia or azospermia. So we can think about issues in terms of pre-testicular, testicular, and post-testicular. So hypothalamic disease, pre-testicular, very important. Are you producing enough FSH and H, like Kallmann syndrome? Then you can have other rare, incredibly rare things, which I've only seen 3 cases in my last 30 years. Then you have pituitary disease, which is much more common. So hyperprolactinemia, even in the men, sometimes it's important. Exogenous hormones is probably the most important thing. I would see probably 2 couples every week where the man has been on androgens. He's going to a gym, he's really pumped up, and he's taking lots of testosterone. Testosterone in men is the most powerful contraceptive. It'll drop your sperm down to 0 within a month and a half. 0. And sometimes I ask the men, I said, why are you taking it? Well, because I thought I wasn't having sex now, I needed to. But I don't think there's a realization, most of you would know, that it would drop your sperm down to 0. So it's very important to think about if they're going to, sometimes people do have low testosterone and they may need it, but it needs to be done in an orderly fashion. They might want to freeze some sperm before they start on testosterone treatment. It's quite important. And to get someone to freeze sperm is not expensive. It's a few $100s a year to keep the sperm there. It's not that expensive. So other common things, so there's a whole list of things, but I'm only going to talk about the common things. So chromosomal things, Klinefelter syndrome, it's common. I would see 2 or 3 of those a year, every year. Sertoli cell-only syndrome is also very common. And this is where you have some incidents that happen either through injury or some other issues where the Sertoli cells have died off. And you'll find then azospermia. You'll go and biopsy the testes and you'll find Sertoli-only syndrome. You can also find Y microsome deletions in some people with oligospermia, so that if the sperm count is quite low, we do Y microsome deletions. There's a region on the Y chromosome where bits may be missing. Why is it important to know that? Because Y chromosome comes through from father to son. That means if that man is oligospermic with a Y microsome deletion, every offspring will have the same. And if we know that typically in these kind of patients, if we can freeze some sperm when they're teenagers in their 18 and under 20, most of the time we'll be able to get enough sperm for them to use in the future because the sperm count drops off in their 20s and 30s. Testicular injury, probably the most common. When boys are growing up, we get injured in the testicles, we fall off bikes, we play sport, we get kicked, all sorts of things happen. And it's actually much more common than we think it is. If someone presents with a history of having an orchidopexy or some sort of hernia operation as a child, 90% of those will have defective sperm. It's an incredible marker. So ask that question. It's really important. When you have, so I'm going to talk about testicular injury. When a baby is in utero, around the 6 to 18 week mark and onwards, there is an immune learning so that the body is learning what's self and what's foreign in the baby. So it's actually creating an immune system for itself throughout the second and third trimester. But there are two parts of the body that are hidden from the immune system, the middle of the brain and the middle of the testicle. We don't understand why, but those two are actually shielded from the immune system. That's why if you get certain types of brain injuries or infection, you'll start forming antibodies towards your own brain. And the same thing with testes. If you have testicular injuries, you will start forming anti-sperm antibodies towards your own testicle. Those two bits of the body, we don't understand why, but so that is an issue. Why is that important? You'll see later on. Varicocele are also important, but varicocele are less important than we used to think they were. So you can have a moderate varicocele. It may drop your sperm quality, but it won't drop it down to zero or extremely low. Congenital blockages are quite important. Most of them are idiopathic. We don't know why there's a blockage. But you can also get a blockage because, as I said, of cystic fibrosis as well. Vasectomy is incredibly common. We have so many people on their second partners, third partners who've had previous vasectomies. If a couple with a partner with a previous vasectomy wants to get pregnant, IVF probably is the most efficient and cheapest way of doing it. Once they've been past 5 years, they start forming anti-sperm antibodies, exactly what I said to you before. So if they've had the vasectomy more than 4 or 5 years later, the anti-sperm antibody count's reasonably high. And even if they do get a surgical correction, there's still an issue in terms of fertilization and much lower pregnancy rates. It's also cheaper to get IVF than to get a reversal. Sperm function, so there's motility, maturational defects, immunological infertility, and infection. So as I spoke about, immunological infertility is exactly when you start forming anti-sperm antibodies. And anti-sperm antibodies are much more common than you think. There's also an infection. So people who present with oligospermia, you need to ask, have you had an infection in the past? Have you had mumps in the past? Have you been treated with antibiotics because of swelling or pain? Disordered coitus, as I said to you, people are having sex much less often than we think they do. So that's important as well. Medications, there aren't many medications nowadays that people take, but obviously chemotherapy, calcium channel blockers, but the most important one is testosterone itself. Now, varicocele may improve sperm quality, but doesn't always improve massively the numbers. Sometimes you can have duct obstruction from previous injuries or because of hereditary issues. Sperm aspirations we can do. We can easily pop a needle into the testicle and get some sperm. If they've had an orchidectomy or orchidopexy in the past, as I said to you, that's important because 90% of those will have abnormal sperm parameters. Elevated prolactin is also an issue because it directly hinders with the LH feedback. This is an old picture. We don't quite do it like this anymore. Nowadays, we just make, so if we're taking an open biopsy, we would make a 1 centimeter cut on a testicle through the scrotum, through the tunica, into the testicle itself, fish out a whole bunch of tubules, and then stitch up the tunica, which is that white, and then the scrotum on top. Here, the whole testicle has been delivered through the scrotum. We don't do this anymore, okay? So, what can help? So if there is a markedly low sperm count, poor quality, we can either help them by doing intrauterine insemination to try and improve the amount of sperm that would deliver to the end of the tube. That would improve the fertilization rates and therefore the pregnancy rates. We need a count of at least 5 million plus in a washed sample. So I'll come to that in a little while before we can offer intrauterine insemination. Once your washed concentration is less than 5 million, you're talking about IVF territory. Once it's less than 2 million, you're talking about ICSI territory. Okay, now I think this is probably the business end of our talk. Out of all the tests we do as doctors, we're used to doing a test and looking at the normals in the brackets, right? We say, right, if we do serum rhubarb, the normal is between 2 and 10. And it's told us those in brackets. Same thing with semen analysis. However, you've got to realize that when you ask for a semen analysis and you're looking for normal parameters in a semen analysis, it is the one test that we do where the normals are not looking at the people that are sitting in front of you. It's a complete waste of time. Why do I say that? Because the normal in a semen analysis are people who have a read of this. The distribution of values for semen parameters for men whose partners became pregnant in the last 12 months. So when we look at a semen analysis, if you go around, just go to Joondalup Shopping Centre and look at men between 20 and 40, and we do a semen analysis, say, randomly, you'll see normal levels exactly that you see in your semen analysis. But those aren't the people we see. Those people who come to you because they're not getting pregnant. Those normal levels do not apply. So what is a normal level in a semen analysis? This is WHO 5 standard. So this is what's in your normal variation. So when you do a semen analysis, this is what it says is normal and it's acceptable. What has this to do with the patient that sits in front of you? Nothing, because it doesn't actually tell you what you want to know. All right? So when you ask for a semen analysis, you've got to see exactly what's going on, and I'll show you what's normal and what you should be looking for. So when you look at these centers, only about 5 years ago, we're now doing WHO 5, which is actually here, the 5th centile. Prior to that, it was WHO 4, which was this, so we accepted this as normal. But in fact, where we probably need to be looking as normal is about here. So those people sitting in front of us, so these are men who've got their partners pregnant. These are men who have not got their partners pregnant. These are the normal levels we should be looking at, which is not what our semen analysis parameters tell us. What's also important is this study, there's lots of studies like that, but this study was done in an American prison. So they know that these men that are sitting in prison, they're going to be masturbating. So I said to them, every time you masturbate, or every other time, can you give us a sample? Okay. And they tracked these men for many, 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 many days. You can see this. It's important now. Why is it important? Because there is variability. There's a lot of variability. Okay? So a one-off semen analysis is not enough. You have to do at least 2, and at least 3 or 4 weeks apart. Okay? Don't do it. Sometimes I get referred to someone who's had 2 semen analyses a week apart. Don't do that. Okay? It needs to be at least 3 or 4 or 5 or 6 weeks apart. Don't do it too close. What affects semen analysis results? It's a time between production and testing. Because I said to you, do you remember that if you produce a sperm in the middle of a testicle today, it takes 75, 80 days for that sperm to come through. So in that 75, 80 days, things can happen to that sperm, and I'll go through all of those things with you. What is the period of abstinence? So less people are having sex less often. If you actually ask a bloke, how often do you ejaculate? There's a lot of men under pressure who are working. If you actually ask them, say, no, I haven't ejaculated for at least 2 or 3 weeks. And what that does, it actually kills off a lot of the sperm behind it, wanting to come through. So you need frequent ejaculations, at least twice, 3 times a week for people who are trying to get pregnant. You have to be creating new sperm to come through, to wash through. It's often funny when I have a couple in front of me and I say, listen, you have to ejaculate 3 times a week. It's not often that a doctor tells you have to ejaculate 3 times a week. So it does happen. When you send someone off for a semen analysis, they give them a pot this size and they say you need to collect it all. But when you actually ask them, did you collect it all? So often they say, well, I missed the first little bit. In fact, that's the highest concentration. And the first bit of the ejaculate is the highest concentration. So you have to explain that to them. Testicle size is important. So if you've got small testes, you know there's something going on. Now, so what can semen analysis tell us? Okay, so this paper looks at the association between semen analysis and chance of fathering a child without treatment. So a single sample is very, very little. But what we're actually looking at is this here. So we know that these are the normal levels we say is okay. These are the normal levels we say is okay, but it actually isn't. These are the levels that we should be looking at, okay? Which would correspond to the 25th or the 50th centile. Okay. Now, one of the things that every time you send someone for a semen analysis to a general lab will do a semen analysis only. That means they're looking at the volume, they're looking at motility, they're looking at morphology, they're looking at concentration. But this is the kind of stuff we've been measuring for well over 100 years. But we are now in 2025. To look at these patients, we actually need more than just this. We need DNA fragmentation and we need anti-sperm antibodies, exactly for the reasons that I said to you. Now, what is DNA fragmentation? The sperm is a unique cell in that its cytoplasm is actually in the head itself. Oh, sorry, the nucleus is the head itself. The cytoplasm is in the tail. The nucleus, which is the most important thing, is bound up in a number of layers, and the DNA is very specifically wound and concentrated into a very small space because they have to penetrate the egg. That membrane can fall apart. It can fall apart due to lots of reasons. And if that membrane starts to fall apart, that's DNA fragmentation. We need to know, does someone have high DNA fragmentation? Why is it important? Because it's a good predictor of chances of pregnancy. It's also a good predictor of miscarriage. With higher the DNA fragmentation, higher the miscarriage rates. So apart from just a semen analysis, they actually need DNA fragmentation. So every one of our subfertility patients, whether there is a male factor or not, will always have a semen analysis with DNA fragmentation and anti-sperm antibodies. And it's incredibly how often you'll see that they're abnormal. When you send a patient to a general lab, Clinipath, Westerns, none of them will do these other tests. It can only be done at a fertility unit. And most fertility units will do this for you if you send them. Just for a semen analysis, but you've got to ask semen analysis plus DNA frag plus anti-sperm antibodies. That's what you want. Infertile men have higher levels of DNA strand breaks and other DNA defects. And we also find that when you've got, you'll have normal spermic men, but their DNA fragmentation rates are higher. And the main mechanism of DNA fragmentation is oxidative stress, and the stress is mainly migrating through the epididymis. What are the stresses? So in that 75, 80 days I explained to you, what can affect these sperm? So you can see that there are a number of things. There's pollution, radiation, smoking. Smoking not so much as it used to be, but in fact, vaping is a major issue. And in fact, the nicotine that comes through in vaping is far higher than cigarettes. So it's actually not that benign. Other drugs, gland infections, prolonged stasis, so you need frequent ejaculations. Okay, immature abnormal sperm can come through if it's abnormal. Varicocele can affect it. But other diseases, diabetes, cancer, systemic infection, can all give you increased DNA sperm fragmentation. Can it be reversed? Yes. So frequent ejaculation helps. Diet helps. So from our previous speaker, diet's really important. In fact, one of the things that you probably all heard about is Menavit. So Menavit is good, but in fact, better than that is a good, healthy diet. Mediterranean type or an Asian type diet, low meats, high quality olive oil, all of those things have been shown to in fact be even better than Menavit. So colored fruit and vegetables, balanced diet, changes everything. Why is doing the other things important? If you look at this seam analysis, okay, we can see here that the volume is normal, concentration is normal, ejaculate is normal, all of these things are, morphology is normal, but when you do a DNA fragmentation test in this person, you can see that the DNA fragmentation rate is 53%, it should be less than 20, okay? So it's important to look for these tests. Same again here, normal, normal, normal. Morphology is slightly a little bit low. Often people ignore the morphology, it's quite important. So when you look at a seam analysis like this, we see here that morphology is only 3%. And if you're looking at a total concentration you have 22 million, if you only got 3% normal, so most blokes will actually ejaculate 90% sperm, absolute rubbish. You'll have sperm which are going around corners or just wiggling around, not going where it's supposed to go. The only sperm that's going to get her pregnant are the ones that swim in a straight line, go where they're supposed to go. So when you look at that fraction, so we have the ability in a fertility unit to take a sample, separate it, gel separate it, so you've got all the rubbish on one side and only the fastest swimmers, which is the ones that's going to get her pregnant. And when you look at that concentration, we want at least 5 million plus, as I said earlier. At 5 million plus, you can offer intrauterine insemination. Under 5 million, you're talking about IVF. Under 2 million, you're talking about ICSI. So even though sometimes we see level, you think, oh, but that's normal. You get this, but then when you look at their trial prep, so you look at this, so we've done this. We've looked at this, we've done a trial prep of these, and you see here the yield is 2.8 million only, okay? Halo of 70%, this is a DNA fragmentation. So although you think this is not too bad, and often I'll get patients referred like this, oh, but their semen analysis was normal. It's not normal. Same again. So these are just similarly recurring themes. So the message is you don't just need a semen analysis, you actually need other things as well. So a normal semen analysis has actually very little predictive value on conception. The conclusion is you need other things in this day and age combined with what you're doing. So it's unreliable, more value if it's done in an embryology lab, and we at Fertility North will do this for you if you want to. DNA fragment rates are discriminatory for spontaneous pregnancy. High DFI is associated with reduced success rates even with IVF. Dietary changes and antioxidants are important. As I say, we will do this for you at Fertility North, and you have to request it. If the semen count is low, so I'll come back to the last point now. So what are the tests that we would like you to do? Often we'll see patients who are sent in with a liver function test, they'll have U's and E's, they'll have their liver functions done, they'll have the lipid screens done. What we really want in the men is an STD screen. We want ureaplasma. We want an FSH and LH level. It is the most important test, FSH and LH. It's routinely never done. So out there, you're the guys at the forefront. That's what we would like, LH, FSH, and refer your semen analysis to a fertility unit to do those three things. Okay, that's it. That's important. Okay, thank you.
Thanks for your talk. Number one, how much is the price of the DNA fragmentation?
If you do the whole test, I think it's about $150, but it's about $150 to do the whole lot. And you'll get some of that back from Medicare.
And you mentioned about the ureaplasma. Unfortunately, we have the difficulty in treating the ureaplasma because it's been...
Sorry, I made a mistake. So when you ask for ureaplasma, you must ask for a culture, not
PCR.
Yeah, because that's high in lots and lots of people. You must ask for a culture. That's the most important thing. And you highlight it, culture only.
Thanks.
And you only treat the culture. So if the culture is positive, you treat both the boys and the girls. You give them doxycycline 100s for 7 days for both.
Any further questions? Oh, no. One more there.
So, with the young guys taking TRT when they don't need it,
Sorry, I can't
when the guys are taking TRT and they don't need it, do things revert back to normal after a period of
It's
ceasing
actually
it?
really difficult. I've got so many patients at the moment, exactly the same story. So you've got to get them to stop, but we often use HCG on them. We may use some letrozole on them. We may end up by using some going left. The stuff we use for the girls, we use FSH on them. And sometimes it takes 6 to 12 months before we go back. But if they've been taking it for less than 6 months, if you stop it, it'll take about 3 to 6 months before they start to produce good quality sperm. It takes some time.
Yeah, there's guys that are on it in primary care. They're just using it in the gyms from mid-20s to mid to late 30s and not thinking about kind of long-term consequences.
It takes a long time. If they've been using it for 5 to 10 years, I've found a number of patients, we never get back to normal levels. It's really hard.
One quick question from me, just the practical side, if you're inviting us to refer patients for semen analysis, do you want them to be phoning to advise they're coming, or I imagine the lab...
No, they can't walk
exactly.
in. They can't just walk in. These appointments have to be made because they're scheduled at a certain time. So we've got so many of our own patients, so we'll schedule them in, but they've got to book in. They've got to book in, and you need to tell them when they book in that they need to ejaculate twice, 3 days before their test. Twice on the same day, 3 days before their test. And you should, even if you're not going to send to us, you're going to send anywhere else, even to a normal clinipath, you should get them to ejaculate a couple of times, 3 or 4 days before their test. Okay.
Thank you so much, Jay. That was very valuable. Thank you. All right, so it's time for us to have our first break for the day. There should be some morning tea available out in the next room. We'll advise you, as Wendy said, with some music when it's time to come back, but if you want to keep an eye on the time, we'll be starting again around 10:20. Thank you.
No, a bit early. Bit earlier than that, Belinda. It is 10:20 to 10:40. It's now 10:20. Yeah, 10:40. Come back.